Welcome, everyone, I forgot what number this is, 41st Annual Alumni Meeting in the Department of Pathology. Welcome back to all the alumni and, of course, the faculty here. We're very pleased to have this annual event and look forward to an interesting day of research talks and case presentations. This year, for the first time, actually, this meeting conflicts with the International IAP meeting. We didn't have any control over the timing of this meeting since it's tied to the institutional alumni meeting, but realized that this conflict occurred just about the time that I was reaching out to Jonathan about the award, and was very gratified. At first he said, yes, I will be in Jordan that week, and my heart sank. And then he said, but I'm coming back on Thursday or Wednesday. So luckily he's able to be here. Unfortunately, a fair number of our faculty members, including Victor Reuter and Rob Soslow and Eddie Brogi and others, are attending the meeting in Jordan, and so I'm sorry to say that they can't join us today, but they're with us in spirit, and I know Victor's going to be with us virtually in a little while, so you can look forward to that. The format will be as it has been in past years. We have two talks from faculty members on their research in areas related to the interests of the Stewart awardee, which, as you all likely know, is in prostate cancer, so we'll do that this morning. Following a break, we'll have Dr. Epstein's lecture. We'll take a couple hours for lunch, and then this afternoon we have the traditional slide seminar that Mira Hamid will moderate. The evening will start at 6:30, I believe, at the Water Club, and we hope all of you can attend that as well. So without further ado, I'd like to introduce Samson Fine. Samson is an associate attending and GU pathologist here for many years, trained at Hopkins with Dr. Epstein, so one of the people with a close affiliation with him. Samson has also taken on the role of running our quality assurance committee, which is more work all the time. But he has a longstanding interest in prostate cancer, and he's going to talk to us about risk stratification beyond grading. So, Samson, thanks very much.
Thanks so much, David, for the kind introduction, and welcome everyone to the 41st Annual Pathology Alumni Meeting here. I want to welcome Jonathan particularly, and we'll have a chance to reminisce over the course of the talk of some stuff from the past. I was given the unenviable task of talking about risk stratification in prostate cancer beyond grading. And part of this is because, as you've seen from the title of the brochure, Jonathan is going to talk to us extensively about grading. And it's a question from a pathology perspective. As a clinical colleague just pointed out to me, grading is such an important part of risk stratification. Where can we go from there? And so over the course of the next 35 or 40 minutes, I want to take you on a journey of work we've been engaged in over the past year and a half or two, but that's culminated recently in a series of published and emerging publications, specifically in some select areas. And specifically, we're going to focus in tumor quantification, both at the needle biopsy level and at radical prostatectomy. And then as an illustrative example of a prognostic factor beyond tumor quantification, we'll highlight some new work that we've done in surgical margin subclassification in light of new guidelines and reporting features. So those who are recent MSK alumni know that I have a penchant for professional use of Twitter. And so I thought I might frame the issue regarding tumor quantification, at least in the prostate needle biopsy realm, with this tweet. Those who are urology fellows in the audience may recognize the name, the originator of this tweet, Bimal Bindi. He's a uro-oncology, I believe, fellow at the Mayo Clinic. And back at the end of June, he put out this tweet, and he said, what biopsy feature are people using most for disease volume? And that sort of struck me as odd, because as someone who practices, amongst other things, prostate pathology on a daily basis, we spend a fairly inordinate amount of time providing this information exactly in reports. And yet it doesn't seem to be standardized at all. And why might these type of features be important? So I think that story really starts with Jonathan, actually. Back in 1994, in a paper in JAMA, along with senior colleagues now at Johns Hopkins, and really, as we see on the left, right at the beginning right, of the spike of cancer detection in prostate at the beginning of the PSA era, Jonathan and colleagues identified features that are associated with insignificant cancer, the so-called Epstein criteria, and therefore in whom immediate therapy could be deferred. And I won't read off the features. I think most who are clinically oriented in the room and pathology as well are acquainted with them. But importantly, these, in sort of a conglomerate form, have formed the basis of the very low risk category of the NCCN guidelines, for quite a while now. And you see that functions like the number of cores positive or a tumor volume in any one core, maybe even millimeters of cancer in a core, are important features here. Yet beyond that, if we look at the NCCN updated guidelines, this is from this August, where they've introduced favorable, intermediate, and high and very high categories, we see a sporadic use of tumor quantification. So in favorable, intermediate, there's a percentage of biopsy cores positive, less than 50%. And then in very high, there's greater than 4 cores of high-grade disease. But it doesn't seem to be a consistent manner for incorporating tumor quantification. So I began to ask myself, why is this exactly? Well, there are a number of challenges in tumor quantitation, and I think anyone who's practiced in a variety of settings, and I know we hear this from our community colleagues, recognizes the challenges of core fragmentation. If you're in a center that only puts 1 core per cassette or has excellent histotechnologists who have been at this for a long time and do their best to get 2 or 3 cores in 1 cassette, then you might be able to have an easier time determining a number or percentage of cores. But as seen in the example on the lower left, and in the corresponding block image there on in the middle, sometimes it's very difficult. And if you were going to use a risk prognosticator like the one shown on the right, which is the CAPRA score from UCSF, which requires you to enter a percent of biopsy cores involved with cancer, you could see how core fragmentation would make this difficult. This is also true. This is the Stevenson, pre-operative nomogram predicting 10 or 15-year biochemical recurrence-free probability, and this also requires a number of positive cores and a number of negative cores. It's a little old, but still used in some settings for prognostication, and so again, the issue of core fragmentation. Furthermore, the impact of determination of cancer percent in length in millimeters is significantly impacted by how you evaluate interfocal stroma. I think those who have encountered Dr. Epstein's talks in the national and international communities or consulted him know that he favors the approach on the left, which is that to measure discontinuously. But one can note that if one takes the opposite approach and subtracts interfocal stroma, that you might end up with 3 foci of cancer, but involving radically different percentages and number of millimeters of the core, which could affect their input into prognostic nomograms or other risk stratification tools. There's data to support both of these, actually. The first study is on top is from Dr. Epstein and people who have worked with him over the past number of years in 2011 in AJSP, showing that there was a difference in up to 80% of percentage of any core depending on the approach you used, but that the discontinuous method, measuring the entire length, as it were, the entire extent, more strongly correlated with stage and margin status. The study on the bottom is Tarek Bismar's work. Peter Humphrey is included on this, where they looked at various interfocal stromal lengths to see if any one of them better stratified the discontinuous and found no significant difference, albeit in univariate analysis. This is another issue that we have in bringing quantification into the clinical realm. Yet, we know both from data from Johns Hopkins, which is the upper study, and data generated here at Memorial, that if we add these biopsy features to a grade, clinical stage, PSA, that all of these add significantly to prediction of pathologic stage. And so the question is, bringing back to the NCCN guideline slide, why are these factors not as correlated? And in a couple of slides, we'll get to areas where I think this is very acute for things that are happening in the field right now. For a moment, though, and I promised I wouldn't talk about grade, so I'm actually not going to focus on most of the stuff in this slide, but I want to set up an increasing focus that has come on the quantification of high-grade disease in the needle biopsy realm. To me, this stems from the 2005 International Society of Urologic Pathology Consensus Conference, which Dr. Epstein led. And specifically, I want to focus on the scenario discussed there, one of the sort of grading rules that was laid down by that conference, the setting of abundant pattern 3 with any pattern 4. Was it ignorable or not? And the wide consensus there was to include the pattern 4. But over the next decade, leading up to the 2014 International Society of Urologic Pathology Consensus Conference on Grading, there was a major change in the field, and that was the increased uptick of active surveillance as a management modality. And so reporting of percent pattern 4 was introduced at the conference in 2014, which was attended not just by pathologists, but by urology and urologic oncology colleagues, mainly on the strength of its potential of potentially including patients in surveillance with low volume pattern 4 disease, and was quickly adopted as a recommendation by the WHO classification, published in 2016, but formulated just a year later than that in 2015. What do we know about reporting percent pattern 4? So this is a study from the Hopkins group showing the inter-observer reproducibility of percent Gleason pattern 4 on prostate biopsies. And this paper published in 2016 in AJSP showed quite good reproducibility, at least within plus or minus 10% in the majority of cases, but with the important caveat that this may be less reproducible when the entire cancer volume in the core is less than 10%. You can imagine a little focus where you're trying to decide amongst a very few glands. You say, I know there's some pattern 4 here, either as a fused gland or a poorly formed gland, but how to quantitate it without making it sound outsized. This was followed by this study from the University of Michigan. They looked at almost 1,700 patients over a range of Gleason scores. They used the approach of taking the overall percent pattern 4, meaning the needle biopsy tumor millimeters of pattern 4 over the total millimeters of cancer. Their real outcome, because of limited follow-up, was adverse pathology, meaning either primary pattern 4, 4 plus 3 and above, or greater than or equal to PT2 stage. And importantly, they were able to show in their series that some percentage less than 50%, okay? So there were 3 plus 4 patients between somewhere in the 20 to 50% range that already showed a significant uptick in adverse pathology at prostatectomy, while also highlighting that there is a group of Gleason 6 patients that also show such adverse pathology, 4 plus 3 and above, at the time of prostatectomy. So recently, our group here at Memorial the GU Path Group, in collaboration with Dr. Bafar Adai and Lucas Dean, who's a urology fellow here, began to ask what the ideal way to quantify Gleason pattern 4, and specifically in the scenario where we think it's relevant to active surveillance. So we looked at about 450 grade group 2 Gleason 3 plus 4 patients on needle biopsy, all who went to radical prostatectomy. The cohort was controlled for age, PSA, a percent cores positive, and also importantly, whether they just had a systematic biopsy, the traditional 12 cores, or systematic plus an MR targeted biopsy. We used the definition, the common definition of adverse pathology at radical prostatectomy in the literature, which is, as stated before, 4 plus 3 and above, and pathologic stage T3 and above, but also applied a second adverse pathology definition, something even more strict, right? 4 plus 4 and above, non-focal extraprostatic extension, or worse stage. And we were able to show the following things, and these results were recently published online in the journal Urology, that looking at 3 different variables, whether one takes the maximum percentage of Gleason pattern 4, or as the University of Michigan group did, the overall percentage of pattern 4, or just the absolute number of millimeters, that each of these factors increase the odds ratio for adverse pathology. More importantly, we went on to the next step where each of these factors were shown to increase the predictive discrimination for adverse pathology beyond the base model of the elements included above. And this is reflected in this graph here. It's called an Apechnikov curve for those who are not familiar with it, showing that as you increase the total length of Gleason 4 on biopsy, the probability of adverse pathology goes up. For those who are wondering what the gray shading is, that's the percentage of patients with that number of millimeters of pattern 4. So we can see that the majority are clustered in a relatively low number of millimeters, but as you go out, the adverse pathology goes significantly up. So I'm going to spend a bit of time on this slide because outside of the urologists in the room, people may not be as familiar with this statistical methodology. So measures of discrimination such as area under the curve or ROC analysis can tell you how predictive a model is or a variable is compared to other models. But they really tell you nothing about clinical utility. And so we employed in this case a decision curve analysis, which shows you the net benefit to clinical decision making across a range of thresholds, right? Meaning, would you intervene at a given risk to the patient? So for instance, at a 60%, knowing that you had adverse pathology, would a certain number of variables help you? For reference, I'll show you that this point here, where these two curves cross, and I'll explain them in a moment, is the actual prevalence of adverse pathology in this data set. The solid line going across the bottom represents a treat none strategy. If you're not going to treat anyone, there's no net benefit to any of your variables. The downward sloping curve here represents a treat all philosophy, where regardless of the variables you're looking at, you're going to treat all. And you notice that it precipitously falls off as you approach the prevalence, because before you reach the actual prevalence of disease, you'll treat everyone. You'll harm patients potentially, but you will catch cases, as it were. But once you hit the prevalence, you're not going to catch any more cases with a treat all strategy. The decision curves over on the right actually take a number of variables and say not a treat none or a treat all strategy, but how do these help you? And specifically, I want to note to you the bottom curve, the dashed gray line, represents our base model, the usual clinical pathologic factors, and then the three measures of quantification of pattern 4. And I think it's clear to see as the arrow denotes that length of millimeters is the factor that increased the net benefit to decision making across this clinical range of thresholds. I think specifically from the 50 to 80% point. This being said, or another way to say this is, if the patient had a 60%, if the patient knew that there was a 60% chance of adverse pathology, would they want to not be surveyed as opposed to intervened with? And I think that the millimeters of 4 adds to this analysis. How to interpolate that to practice. So I'm going to, in the next couple of slides, highlight areas in which I think this may be highly relevant in collaboration with our clinical colleagues in moving care forward. But I wanted to start with this slide. It's something that I put together relatively recently, but just to keep in our consciousness, right? These three colorful arrays represent Gleason scores 3 plus 4, 4 plus 3, and 4 plus 4 in representative patients, but focus on the same number of millimeters of grade 4 cancer, 0.7 millimeters. We can see that depending on where one hit with their biopsy, how different patients could be classified as any one of these grades, but still have the same number of millimeters of pattern 4. And this has begun to increasingly bother me, and specifically in these realms. So the next couple of slides relate to the potential impact of reporting of quantification globally, and specifically of pattern 4 in a number of areas. And we'll focus on MRI-based biopsy strategies and look at a recent major clinical trial in that area. The evaluation of genomic classifiers, are they helpful? Do they add information? The prognostic value of morphology. Specifically focused on cribriform morphology, and then something we don't think about so often because a lot of this is correlation of needle biopsy and radical prostatectomy, but in the management of radiation oncology patients. So many of you may know, this has received a lot of bandwidth in the lay press, about this New England Journal of Medicine article, the Precision trial published in May. MRI targeted versus standard biopsy for prostate cancer diagnosis. And this was the scheme of this trial, and they basically took 500 biopsy-naive men who either had an increased PSA or an abnormal digital rectal exam and stratified them 50-50, multiparametric MRI or go to a standard transrectal ultrasound biopsy, 12 cores. Within the multiparametric MRI group, we'll focus first, they divided them between non-suspicious and suspicious based on the PIRAD score, very similar to some of the other scoring systems like in breast and elsewhere. But for the low PIRAD score MRI patients, they did not perform any biopsy, and so therefore no cancer was detected. Within the higher PIRAD score, they took MRI targeted biopsies only and showed a 38% clinically significant prostate cancer detection rate and a 9% clinically insignificant prostate cancer rate. Those who underwent 12-core biopsy had 26% clinically significant cancer, 22%, a significantly higher rate, insignificant cancer. And so the conclusion of this study and sort of the soundbite that came out of it was a 12% increase in clinically significant cancer with MR-targeted biopsy and a 13% decrease in the clinically insignificant cancer. The problem with this study is that from the pathology perspective, is that the definition of clinically significant was Gleason score 3 + 4 = 7 alone. There's no tumor quantification in here, let alone pattern 4 quantification. And for centers who would consider putting a low volume 3 + 4 patient on active surveillance, these may not actually show much of a difference. In addition, in an editorial recently, Dr. Pat Walsh from Johns Hopkins pointed out that in this particular group where no biopsy was performed and then therefore no cancer detected, there's another clinical trial, the PROMISE study, I believe it's called, which showed that up to 24% of patients in this group end up showing clinically significant disease, defined here, 3 + 4 = 7, when they were followed up. And so where is the role for the pathologist in this? As the era of MR-targeted biopsy emerges, we need to help define a number of things, but I'll focus on two. Number one, in terms of general tumor quantification, should we consider these equal number of cores, or should it just be considered one site? If you take 2 or 4 or 6 or 8 or more cores from one MR-targeted lesion, how many cores should that be? And that might influence management paradigms. And further, and related, is how to evaluate tumor quantitation in these patients. Moving on to the impact on genomic-based testing. These are the three most common, RNA expression classifiers that are out there. We're going to just focus on two of them. First, on the Decipher genomic classifier, which the clinical endpoint of is metastasis. And what people have shown in a series of studies is that if we look at the red curve on the graph at the left, adding a Decipher genomic classifier score above NCCN classification allows you to predict metastatic risk. It's also been shown in the orange curve here on the right that there are a percentage of Gleason score 6 patients who have Decipher scores that put them in the metastatic potential site. Again, caveats. The factors included in the multivariable analysis in terms of showing that these classifiers are added, no mention of tumor quantification, no mention of quantification of high-grade disease. And in addition, although I'm not going to focus on it beyond this, issues of heterogeneity. If you're submitting a needle biopsy from a patient, questions of intra and intertumoral heterogeneity are really, in some ways, unaccounted for and have been shown to be quite great in prostate cancer. Furthermore, in a study presented at AUA in 2017, our colleague Bafar Adai, looking at 17,000 men who had the Prolaris cell cycle progression score and using a predetermined cutoff under which you were considered active surveillance eligible, looked at it in a number of groups that would otherwise have been traditionally disqualified from active surveillance based on, for instance, the Epstein criteria, such as grade group 2 or greater, 3 + 4 patients. And they showed that nearly 50% of such patients would have been shown by that number less than or equal to 0.8 to qualify for active surveillance based on the cell cycle progression score. And so again, this is another area that probably calls for some nuance and quantification of high-grade disease to see whether these genomic classifiers, while very biologically interesting and we can learn a lot, actually will add in prognostication. Turning back to pathology for a moment, I think most people who have been practicing prostate pathology on a daily basis know that there's been an explosion of literature around cribriform prostate cancer. We're not going to deal with the grading elements of it, but just to show two aspects. Number one is the concept of a nimbosis, as it were, or a gathering of small clouds. Multiple groups, and specifically a large group, a collaborative group that Dr. Gopalan, Dr. Reuter were involved with, have shown that cases with intraductal carcinoma and cribriform adenocarcinoma taken as a group show a greater percentage genomic alteration than those without. And that seems to correlate in a number of studies with prediction of metastasis and disease-specific survival. I've only highlighted the two studies that have focused on hard endpoints here. And so, for instance, if you have 3+4 with and without, and 4+3 with and without, this morphology seems to add information in terms of prediction. But there's a cautionary tale here. The most recent study from the group in the Netherlands, Dr. Van Leenders, Dr. Van der Kwast, Dr. Kweldam, that's quoted here, was in 2017. And here they were trying to compare quantification of pattern 4 and cribriform and intraductal carcinoma. And this line was, to me, instructive. Said, while invasive cribriform and/or intraductal carcinoma performed better than a high percentage of Gleason pattern 4 in 3+4 = 7 patients for prediction of biochemical recurrence-free survival after radiation, both parameters were insignificant in analysis adjusted for PSA, simply the number of positive biopsies, and tumor volume. And so I think this is a cautionary tale of the need for careful multivariable analysis before we jump on the bandwagon of individual morphologies and their predictive value. Finally, in the realm of needle biopsy is what I'll call a tale of two patients. You'll note that patient A and patient B in this, and I'll give you a minute to look at the percentages and the like, both have 4 cores positive. You'll note that the highest grade group on the left is grade group 2, 3+4 = 7, and that there's a small focus of grade group 4 over on the patient on the right. Slightly different clinical picture, a little higher PSA on the right, but the reality of these patients looked at from a perspective of quantification of pattern 4 is that the 3+4 patient actually has more pattern 4 in their biopsy than the patient who would be classified as 4+4. And that's really important from an NCCN perspective because the patient on the left is considered favorable intermediate risk, the patient on the right is high risk, and in the radiation oncology management pathway, this is a significant difference. It's a difference between getting external beam radiation or brachytherapy alone and adding up to 2 or 3 years or maybe as little as 18 months of androgen deprivation hormonal therapy, which is not an insignificant or non-morbid therapy. And so this is another area where I believe that tumor quantification, and specifically the quantification of high-grade disease, may help in the future. So as we transition over to the radical prostatectomy part of the thought, I just wanted to, show some relatively ancient history. It's new to me still because I can't believe I've been here 13 and a half years. But this was our fellowship class with Dr. Epstein. It's actually just 2 of us. The rest are faculty in the back row. But Dr. Tamina Ali and I in 2004, 2005 had the opportunity to train with Jonathan. That was before the era of 4, 5, 6 fellows, international people, and the like. But it was a wonderful time and productive time. Focusing now in radical prostatectomy for a moment. What about tumor quantification there? So our story really starts in the 90s with 3 studies dealing with various aspects of tumor quantification. First is from the Hopkins group, showing that tumor volume correlates with grade and margin status, but was not an independent predictor. Along the line, and I've just highlighted the study from JAMA in 1999, there's the strong work or the strong position of the group at Stanford, Dr. Stamey and McNeil and Yamoto, showing that % of high-grade disease and cancer volume were highly predictive of BCR, and they went as far as to say that if you included these in your predictive models, you could actually take Gleason out. Okay, that it was the % high-grade disease and the tumor volume that were the most important. The Harvard group, Dr. D'Amico, Dr. Renshaw, were advancing the position that maximum diameter of prostate carcinoma was sort of the simplest, inexpensive, easiest way to do this. And they showed that it correlated well with tumor volume in a series of studies, with the caveat that the follow-up to this study in 785 patients that included, in multivariable analysis, surgical margin status, maximum tumor diameter fell away. So over the next decade and a half, there are numerous studies that show a well-established correlation with grade, stage, and tumor progression for tumor volume and or size. But the majority of the studies, at least that had significant enough follow-up and significant enough numbers, failed to show independent predictive value. There's also no accepted standard for measurement. Not every pathology department, and the colleagues in the audience can attest to this, are doing this the same way. It would theoretically have to be appropriate for routine practice, not something that's going to add an hour on to your sign-out. And even objective measures, so-called objective measures, are subject to embedding issues, tissue shrinkage issues, and whether you're measuring the dominant or index lesion versus the overall volume or size. Nonetheless, in a consensus document published in 2011 and reflecting a 2009 ISA meeting, most pathologists felt that, experienced GU pathologists there felt that we should include some measure of quantification, but there was no agreement as to what we should do. Subsequently, in recent updates of the International Collaboration on Cancer Reporting, and more specifically the CAP protocols, tumor quantitation became recommended and required, either in the form of a % involvement or a tumor size of the dominant nodule. And this is problematic specifically in our practice because we were not in the habit of giving tumor quantification, and being a center that has moved to CAP compliance to fulfill the needs of the Commission on Cancer of the American College of Surgeons, which is associated to CAP, we felt we needed to study this as we began to include it de facto. And so in a study just published this month in Journal Urology Online, we looked at the clinical utility of a variety of prostate and tumor volume related parameters following radical prostatectomy. We had about 1,300 patients. A base model was adjusted for age, PSA, grade, stage, and margin status in these radical prostatectomies. And what we showed by creating a number of models, the base model plus 6 different factors, is that while we could show a very small improvement that had a significant p-value for high-grade tumor volume over tumor volume, meaning % high grade, reminiscent of the Stanford group's suggestion, when we looked at it in a clinical utility type of sense, i.e., if I had a certain risk of biochemical recurrence, would I intervene and give early adjuvant radiation therapy? You can see that as opposed to our decision curve analysis before, the curve on the right in yellow representing the high-grade tumor volume over tumor volume is flat on the base model, meaning it did not add any clinical utility. And so this is one indication not to recommend routine reporting of volume in radical prostatectomy specimens. We went on to look at it in a specific subgroup, and that is organ-confined prostate cancer. Why look at it there? Because there's been evolution in the classification. I think those who've been around for a while know that PT2 disease, for those signing out radical prostatectomies, has evolved from 3 to 2 to 3 to 3, and now finally to 1 PT2 staging. Why did that happen? There's a lot of evidence of why to change PT2 classification. It was shown not to convey prognostic information. It had a poor correlation with clinical T2 staging, which was the reason of trying to keep it as a unified three A, B, and C. Pathologists had poor reproducibility in assessing less than half versus greater than half of one lobe due to issues of shrinkage and tumor deformation in the surgical pathology practice, and it also led to the sort of nonsensical scenario of a unilateral large tumor, PT2A in the old classification, being assigned a lower stage than 2 small 3+3 cancers, which would have been PT2C. And so in this most recent AJCC 8th edition, due to this preponderance of evidence and sort of common sense, all over organ-confined disease is PT2 without subclassification by extent of involvement or laterality. We looked at that as an opportunity to study tumor quantification in this setting because we're not giving a measure of it anymore. So we looked at in work that's in preparation, about 1,700 RP patients with PT2 cancers and tumor quantification data available from tumor maps that have been created over the past decade and a half here at Memorial. Again, a base model adjusted for age, PSA, grade, and margin status, you won't see stage in there because these were all PT2 patients. And what we were able to show is that the hazard ratios, while a couple of them were over 1, the confidence intervals, whether you looked at the whole cohort or just those on the far right that had a needle biopsy with 3 + 4 = 7 or above, which are the patients most likely to go to radical prostatectomy today, that the confidence intervals overlapped 1, okay, in all cases, with non-significant p-values showing that adding that total tumor volume and maximum tumor diameter of the index lesion do not add predictive information for biochemical recurrence in this setting. So again, we cannot routinely recommend tumor quantification at RP. To finish up, just a couple slides left regarding surgical margin subclassification. I think all the pathologists in the room are very familiar with this scenario, that there are really 2 varieties of surgical margin positivity. On the left, we have in the otherwise organ-confined setting in an area of capsular incision. Again, tumor meeting the ink at the margin. And then over on the right, extraprostatic extension, tumor into fat, but also reaching, in that case, the blue ink margin. In the AJCC, we simply assign these as R1. It's a pretty simple system. Yet, over time, specifically over the past 10 years, there's been a movement towards surgical margin subclassification. The research on this sort of starts, in my mind, with a paper in 2009 from Andrew Stevenson, big meta-analysis of 10 studies, or 10 or 12 studies looking at surgical margin positivity, where he showed that in the graphs, regardless of your stage, regardless of your grade, the more jagged line underneath each of these was the positive margin versus the negative margin, that surgical margin positivity adds predictive information for BCR. He then looked at, because again this is a meta-analysis, at the other information that he had, which was on number and extent of margin positivities, and showed that they too correlated with biochemical recurrence, but importantly did not improve the predictive accuracy versus positive versus negative alone. In the same year, Shikhanov and colleagues working at the University of Chicago introduced the concept of the length of positive surgical margins. They had a large number of patients and a decent amount of surgical margin positive patients, very limited follow-up, but were able to show that if you took the usual clinical pathologic variables and added beyond them positive surgical margin length, specifically most significantly length of 3 millimeters or more, that this was a predictor of biochemical recurrence. This was quickly followed by studies. This one is from Jonathan's group at Hopkins. Again, a particular subset of patients, but a decent follow-up and the impact of the grade or Gleason score at the margins. And corroboration of the linear length of positive margin positivity, predicting biochemical recurrence from the Washington University St. Louis, Dr. Humphrey group at the time, with an important caveat, the lower right, that this ability of linear length of positive margin to predict biochemical recurrence sort of fell away as an independent prognostic factor when you stratified by PT3 stage, which was an indication to us that maybe we needed to look at this a bit more. And so you have a lot of things that have been shown to be independently predictive of BCR, but pretty much all of them are coming from single institutions, relatively limited follow-up, probably more importantly, a limited number of cases or events, and most importantly, really no studies with the standard of will it change clinical management? Will this induce the clinician, the urologist in the audience, to give early adjuvant radiation therapy instead of waiting for the PSA to go up? Nonetheless, there's been a movement, and specifically in the CAP protocols, I draw your attention to the lower right, to require, a measurement of length. They do it as focal versus non-focal or focal versus extensive, but they do use that 3 millimeter cutoff from the Shikhanov and other studies that have been published. And so we've looked at this actually twice. We looked at this back in 2013 in an initial group, admittedly only 2 years median follow-up. And we looked at both length and Gleason score, and as you can see clearly from the curves, we were able to replicate the prediction of BCR that others had shown, both for linear length of margin positivity, and specifically the 3 millimeter mark, as well as higher Gleason grade at the margin. That's 4 4 or 5 as opposed to 3 as the highest grade. But importantly, following the meta-analysis approach of Stevenson, we showed in that study, again with the caveat of limited follow-up, that neither of these factors added important discrimination beyond positive versus negative status. And so that's where it sort of stands. We are now, because we're a CAP-compliant institution, recording focal versus non-focal. And recently we said, why don't we go back to that data set and look at it with increased follow-up and see if we can see if there's a signal in a better multivariate analysis. And so in work in preparation with Sean Dason, who's one of our urology fellows here, we've relooked at this cohort. And in the same analysis, using the same analysis we did back in 2013, we found that if you take your base model and you add these multiple measures of surgical margin subclassification, that you really have minimal change to your C-index, to your measure of discrimination. If you look at the overall cohort, meaning if you've included positive versus negative status. And so what that may indicate is if you are generally counseling a patient, okay, before surgery about their risk, that this may not add much to your discussion. However, taking the possibility that this might be important in only the patients who end up having a positive surgical margin, looking at that particular cohort of 207 patients, we've begun to see a signal here. And that signal is that whether you add the maximum Gleason pattern at the margin, or more, I think more significantly based on the change in discriminative index, the change in C-index, the total length of positive margin, or the two combined actually, you can begin to see a signal in a decision curve analysis. But here, very different than what we've seen in the last two of these. One, we saw a very significant separation of the length of millimeters millimeters of 4 in the needle biopsy. We saw an overlapping curves with regard to tumor quantification and radical prostatectomy. Here we see some improvement in net benefit to clinical decision making, but only over a very particular range. And so we feel that this finding needs corroboration from other large series and continued follow-up. Because the clinical standard is still, in most places in the US, wait for the PSA to go up, okay? Don't give adjuvant radiation therapy. So we're not comfortable, based on the limitations of this study, recommending formal routine reporting. However, there is some signal, specifically with regard to length of positive margins, that there may be some value in its reporting. Some take-home messages. Number one, tumor quantification on needle biopsy requires refinement if it's to be further included in clinical decision-making pathways, whether it's overall or whether it's that of pattern 4. But at the same time, we have to ensure as pathologists that the multivariable analyses are including these factors, and also that measures of clinical utility are being studied. We cannot recommend at this time routine tumor quantification of RP, sort of regardless of what the CAP has us doing at this time. And that prognostic parameters, and I've given the example of positive surgical margin subclassification, while we can find statistical modeling to potentially support their reporting, need to be measured against a clinical standard. I'll acknowledge, of course, our GU pathology group led by Dr. Reuter, who you will see from afar in a little bit. Particularly of note, our colleagues from epidemiology and biostats. I am not an epidemiologist, biostatistician. I've presented, I think, some fairly complex statistics today. I specifically want to highlight the junior people here, Melissa Ossel and Emily Vertosik, who have spent countless hours with me on these statistics, and our fellows from the urology service, Lucas Dean, Yujiro Ito, and Sean Dason, who have participated in the work. For those who have been in the MSK department, you may not have seen this hallway before, but you've seen some iteration of this hallway before. This is the Hall of Fame, as it were, in MSK pathology. It records the legacy of the pathology department and all its fellows. And if you go back to 1983, 1984, you can see a young Dr. Epstein who has clearly prepared for his Movember, cameo here, already grown the thick mustache and the like. But I also draw your attention to these two characters who surround him on the far left and the far right, Drs. Reuter and Rosenblum, who I'm sure join me in wishing him the best on accepting this Fred Waldorf Stewart Award. Thank you.
All right, so don't take this the wrong way.
Sure.
I think, you know, a lot of what we've been doing, especially in evaluating resection specimens, is providing more and more information. And I was really pleased that, you know, the effort in the research is to define, you know, what's actually clinically actionable. Has anybody gone the next step to say, and if you act on this, will it change the ultimate outcome of the patient? And how do we tease that out from the studies that you're doing?
So in a previous iteration of the slide, I had actually included the fact that there is no, for instance, clinical trial. Let's take the surgical margin positivity. Ideally, thinking from a clinical perspective, the way we'd handle this is to say, okay, we have a signal about greater than 3 millimeters of margin positivity. Let's put it together with the Gleason grade or score at the margin. If you have this and this, we'll give you early adjuvant radiation. If not, we'll stick with the standard of care, wait for PSA to go up. The difficulty is that right now in the clinical world, and this is, you know, shown over multiple analyses, is the morbidity of radiation therapy is potentially so great that the willingness to conduct such a trial based on a pathology feature is, I think, quite limited. And so right now, the best we can do is sort of find the things that might be actionable, and then put it forward to the clinical colleagues to say, would you consider this? And with this new data, we're on the verge of doing that. Okay?
There is some data kind of, you put two things together separately.
Right.
So there's data that if you are going to recur after radical, immediate adjuvant radiotherapy is better than delayed. And so then based on that, kind of the inference is that if you can come up with pathological predictors who's more likely to recur, put that together, and yes, those patients would benefit from the immediate adjuvant. But as Samson said, there's no direct trials, and you can't really randomize patients because patients just wouldn't be randomized in that sense.
Right, and I think while there may have been some patients in our various centers who, based on the length or combination of the length and Gleason, have been treated, I'm sure there are some at Hopkins, some here and the like, it seems more anecdotal than systematically done.
Does the MRI will alter the way they perform biopsies in the next future?
So I definitely think so. I'll draw your attention back to Twitter. If you look at what the Imperial College London and University College London have been doing, they have essentially been pushing the bar towards transperineal MRI, not targeted, MRI biopsies, talking to clinical colleagues around the U.S. In different settings in media. It seems that some centers, there's a group at MD Anderson actually, 1 or 2 of the urologists who have gone over to this technique rather than the traditional transrectal ultrasound. And the reason is going through, as they say, the poo, okay, leads to increased sepsis and the like. So for those reasons, the biopsy types will change over time, I believe, here in the U.S. as well, and we'll have to deal with all of these issues anew. And with that,
You
anew.
can make a limerick out of that, actually, so, but for another time. Thanks, Samson.